Good morning, everyone. I'm feeling a little odd because I don't know if you can see me. I did wear my high heels thinking this might happen. My name is Cynthia Cabrera. I'm the resource supervisor for CAIR, and this is the team. I'll let them introduce themselves now.
Hello, my name is Leo Edwards. I work out of CAMH. I'm trained as a social worker. As part of CAIR, I'm a clinical facilitator, and I've been in this role for just about 2 years. Prior to this, I've worked at Griffin Center and at York University as a clinical educator.
Hello everyone, I'm Olivia Shaw, and I'm a board certified behavior analyst working at CAMH with Leo, and part of the CAIR team as the ALC, so alternate level of care behavior therapist. And I've been in that role for about 2 years as well, and previous experience across Ontario, London, Ontario as a behavior consultant, York Region as a behavior consultant, and some experience out in London, England. So I'm happy to be here today.
We're part of the CAIR team. Today we'll be discussing the CAIR program overall, how we got started, our mandate, and then the tools that we use to help facilitate developing a clinical plan and transitioning clients from different settings. So our agenda, and I know you guys have all these handouts, is an introduction to the CAIR program. What is CAIR? What do we stand for? The tools that we use, clinical planning tools, transition planning, and then we'll have some wrap-up and questions and a general discussion, depending on how you guys are feeling. So the learning objective for today is to understand what CAIR is. So what is the purpose of our program, and how do we support the community that we are mandated? Understand how CAIR supports very complex clients who have exhausted many resources, who have undergone a lot of treatment or assessment and have still not been able to stabilize and have exhausted ideas, and people are struggling to figure out how to best support them. We will discuss best practices in terms of transitioning clients from one area to another in order to ensure that there is stability, capacity, and future quality of life. So we will overview a case of named Jimmy. You have his case in your files, but he's a 24-year-old man, diagnosis of Fragile X, anxiety disorder. His intellectual disability is unknown. He has physical aggression, punching, scratching, kicking, causing injury. He's been ALC, which is alternative level of care, and he has been in hospital for 7 months, which means that all his medical needs have been diagnosed and met, and there's no need for future medical intervention. The parents are deceased, and the brother is developing SDM. There's disruption in sleep, eating, and general routines. There was a medication review done, PT consultation is available. So generally, this is the type of profile we will be discussing in terms of how to clinically plan and provide transition supports to.
Page 33.
So the big thing is he just got pulled for a spot, which we love to hear those words, but that means that the work has to begin in terms of care planning and transition planning. So what does CAIR mean? CAIR stands for the Collaborative and Individualized Resource Program. Our main objective is to work collaboratively with community partners, families, and caregivers to create a plan that can move with the person as they live in the environment. So ideally, that plan is very individualized to that individual who needs supports, and it is a biopsychosocial review of what the outcomes and the goals are. So the history of CAIR. The community in the DS sector identified that there was a gap in terms of capacity to plan for very complex clients. There were a number of clients that were burning through resources, in and out of hospitals, family burnout, that the community was struggling to find supports and or plan for. So it was a pilot project that started in 2011. It was funded with the Ministry of Community and Social Services. Once that pilot project was underway, the LINs came to the table with CAMH and identified another pocket of need, which is the alternative level of care clients who have been holding spots in hospital settings and treatment beds, and that needed movement. So the ALC program is a part of the CAIR program, an umbrella program, so to speak. So together we form the CAIR ALC program. So again, it is a partnership program between CAMH, Griffin Center, and the Community Network of Specialized Care Toronto Region. Olivia and Leo work out of CAMH, and I work out of the Griffin Center. So again, funding for our programs is through the Ministry of Community Social Services, Toronto Network of Specialized Care, and the TLC Services is the Toronto Knights. So the CARE team, as we've introduced ourselves, is composed of us three. So I'm sure for some of you, you've already worked with us, so you know it's just us three. So what is CARE? CARE is a time-limited, comprehensive intervention and clinical planning program supporting adults with developmental disabilities and other mental health or aggressive behavioral challenges with complex needs who require an extensive clinical plan, innovative and individualized planning and response in order to be sustained in the community that they're living in or to help with transition to a community environment that is more suitable to maintain their needs. And that's usually where the capacity building comes into play. Our mandate is to collaborate with clients, agencies, individuals, caregivers, hospitals, any environment that could probably provide support or resource, knowledge, in order to stabilize and inform the clinical plan. If the client or the caregivers do not have a comprehensive team, one of our mandates is to figure out how we can pull together that team. We provide short-term resources to implement the clinical plan, and that caveat is if all resources have been exhausted, we are able to look at what are the goals that need to be implemented where the receiving agency or the current space doesn't have the capacity to do that. We're able to put in a short period of time, whether it's staffing, resources, or training, to be able to address those specific goals. We can make use of ALC services as needed, obviously Olivia's expertise. Our mandate is to enhance caregiver and systems capacity, and what that looks like depends on what the need of that team is, whether it is understanding on how to develop a comprehensive clinical plan, using transition tools, formulating a communication style that fits the needs of that team, or just general knowledge of systems and best practices. And fundamentally, it's to improve and advocate for the clients that we are serving, knowing the many challenges and barriers that we're facing as service providers, that families are facing in terms of providing care. And ultimately, our goal is to improve client outcomes, as we're all here sitting together trying to figure out how to best do that. So our services are primarily made up of these three key elements, which is coordinating an intensive biocycle clinical plan, resource implementation for the interventions that are highlighted within that plan, and fundamentally capacity building across the board. Our overall goal in terms of systems level is to advocate to the ministries, advocate to the different bodies that we speak to. Fundamentally, our goal is to provide stability, learning, understanding of the client's needs, and how best to make resources available or capacity to meet those needs of that individual and or family members. I apologize, I tend to speak really quickly. I'm trying to breathe through it, so if I am going very fast, let me know, just wave or shout or whatever's needed. So this is our service pathway. Generally speaking, referrals and intake come through the Griffin Center. Usually it's connecting with myself. Once a referral package and reports are gathered, we are able to then move on to the next stage, and Leo then reviews all those pieces and supports the team in developing a clinical plan. I get a lot of feedback in terms of the amount of information that CARE requires, and it's important in order to be able to really inform the plan. These reports kind of either have recommendations that due to the capacity we aren't able to implement, or we've forgotten, or just time consumed. So we need to have those reports to be able to fully inform a clinical plan and identify maybe where the resources are needed to be able to carry out some of those recommendations. And from the clinical plan development, we usually identify specific goals, whether it's staff training, data collection, that might not necessarily have the capacity within the community to do. So we are able to put together an intervention plan where some resources are attached, and then obviously service delivery. And ongoing throughout that whole process is community meetings, communication, and obviously planning. So ongoing collaborative review is what we do. What CARE can do: collaborate with service providers to create and implement the clinical plan. mentor and support existing case managers to be able to clinically plan for our very complex clients who have burned out the systems, the care providers, and the resources. Participate in ongoing organizational and treatment planning meetings to be able to fully inform where the gaps are. Provide updates to clinical conference, so we do sit at that table and we do highlight clients that are on our caseload and then also present at clinical case conference. We share evidence-based resources because our planning, our biopsychosocial, our interventions are based on best practices. Provide supports to implement the clinical plan. What we can't do, I'll let that resonate a little bit, fund or resource long-term supports. We all know that sometimes there are nowhere suitable for our clients to transition to. They're either waiting long-term in hospital. The systems that they're in do not have the capacity to continue to care for them because they have changing needs. Unfortunately, CAIR cannot fund those kinds of transitions. We are short-term and goal-specific. And we're not crisis response. Because we are a planned intervention, it might take a little bit longer. And so usually we rely on community resources to really address the crisis, while we as a community try to really proactively plan to minimize future crisis and to minimize future issues around resources and stability. AL service and care. So all ALC clients are CAIR clients, but not all CAIR clients are ALC clients. And I'm going to pass that on to Olivia to further explain.
Okay, and I'll leave that little visual up there as well, because I think it can be quite confusing at times as to what is this ALC service, what's CAIR, how do they connect, like it's very confusing. So this I think is a really good depiction of we're all the same team, there's just a bit more specialty on the team for ALC supports. Okay, so Leo actually has, and Cynthia would have the whole CAIR client list, and then I would have just the sub portion of the ALC clients. So what is ALC? Have people heard this before? This acronym? Yeah, I guess it's becoming more and more familiar with people once we have more contact with more complex individuals, right? And it's a hot topic in healthcare. So if you're interested in that, you can probably find some interesting articles and journals around that. Okay, so it does stand for alternate level of care. Okay, so basically it's an individual residing in hospital in an inpatient unit, and they present with complex needs and are not able to move beyond that setting. So Cancer Care Ontario was the first to come out with what that definition is. So it's when a patient is occupying a bed in a hospital that does not require the intensity of resources or services provided in this care setting. And the patient must be designated by a doctor, so it's not our team designating them ALC, it comes from the medical professional. And again, that there's sort of a clock that starts once they become ALC, and then the hospital is quite aware as to how long the individual's holding up that bed or blocking that bed. And again, often the reasons for them blocking that bed is because they face a lot of barriers to discharge. To name a few, again, some really challenging or complex behavioral presentations. They require maybe a more specialized environment. Literally, the environmental space needs to be modified or renovated for them to move into that, which again costs money, and that may not be available. They may need specialized staffing support, whether that be the ratio or the actual expertise within the staffing pool. And again, a lot of them come with what the complexity comes from this behavioral presentation plus possibly a medical, very, very medically complex, which I know you guys heard a bit on day one about some of those more common medical complexities. So again, you've completed treatment, you've got nowhere to go. So, does it sound familiar? Unfortunately, right? Yeah. I was at an ALC forum yesterday, which was a sponsored event between CAMH, all the major mental health hospitals within Ontario. And some of the stats they were throwing out were just like jaw-dropping. 36% of Ontario healthcare money is wasted. Again, I don't know the specifics of that, but that was one that I think is pretty shocking. And that 1 in 5 beds within hospital settings across Ontario are not available to the public. that sort of just puts it in perspective a little bit. Okay, back to what I'm supposed to be talking about. The eligibility for my part of the service is, again, an individual designated ALC. And again, I think I missed the point that, so in our case, we have included individuals who are definitely ALC in hospital, but we've extended that within the community setting to treatment beds as well. I think there can be that same kind of lack of flow through between those treatment settings, that we would also deem them ALC, informally obviously, and we would then consider them as part of our service and part of our mandate. So just want to clarify that as well. Okay. So again, the individual needs that designation, dual diagnosis, as well as more specifically some unmanaged behavioral issues. So again, that could be self-injury, severe aggression, inappropriate sexual behaviors, exit seeking or elopement, just to name a few. The service, unfortunately, my service does not have access to any community residential placements. I'm putting that on the table. I don't have any special powers or any special connections to allow that to happen. I don't have renovation skills either, so to make those kinds of things happen. So what does the service include? It includes a behavior therapist and myself, as well as some flexible funds attached that again are used where appropriate but across the team to help support that individual as best needed. It's a maximum length of stay of up to 2 years. We always put up to because again it's based on goals, it's based on capacity, and it's again based on progress. And also mobile, individualized clinical support. So I have a car. And I can meet often individuals in the community and be present as much as I can. And again, to provide that possible assessment, behavioral treatment plan, really focusing on just a transition planning model, which we'll get into more detail a little bit later. Or I can be pulled in, which we all haven't been pulled in before, for just staff training and general capacity building of even what is an intellectual disability, what is a dual diagnosis, what's that mental health piece, which the developmental sector is just getting more and more aware of. My role again is mainly consultative and collaborative. Usually we try to pair up with the current supports in that receiving agency of where the discharge is happening. Again, if there is no capacity there, then I would be probably sticking around for a little bit longer. We'd have to be planning, clinical planning around who's going to take it on, because I can't be involved forever. And often if an individual doesn't have a discharge location to go to as of yet, we can be pulled in to do some pre-planning to identify, okay, how can we improve their profile? What are some skills we could teach to make them a bit more ready for the community? Is that community access? Is that using the transit system? Is that, are they taking medications by injection only right now? And how can we move towards them taking it by mouth and having a bit more independence with that? Just to give some examples. Okay, now I'll turn it over to Leo for clinical plan.
Thank you, Olivia. I think the overarching question that is important to ask ourselves is, what is a clinical plan or a clinical formulation or case formulation, as those can be used interchangeably, and maybe more importantly, why is this important? And do I have the competence to do clinical planning, or does it even fit in community context? And I would argue that it fits very much within community context. For the purpose of this talk though, I'll be very brief, as the intention is for transitional planning and not clinical planning. However, a clinical plan precedes a transitional plan, and so in the context of our work at CAIR, it's important that we sort of replicate that. So, can a clinical plan be done in a community setting, and is it useful? And yes, it is. And I'll just draw for some from experience. So prior to my role as a clinical facilitator at CAIR, I worked as a clinical therapist in a program called SAPACY. SAPACY stands for Substance Abuse Program for People of African Caribbean Descent. That program is a community-based program and a clinical-based program. We know cognitive behavioral therapy is an intervention that is very medical-based, and the research shows that when used in maybe hospital setting, that there's some success. But that for some communities, a cognitive behavioral plan needs to be adapted. So in the program at SAPC, what we did is what we call adaptive cognitive behavioral therapy, to take into account the other pieces that may influence people's behavior: context, culture, social location, and all these things. So in the context of our work in the community, and we're going to talk about biopsychosocial, that kind of planning, that kind of clinical planning within that framework can be quite successful. I know the term clinical is very medical, it's from the adjective clinic, and so for some it seems to be very abstract, very cold, and very maybe sort of standoffish. But everybody can do a clinical plan, because a clinical plan really is a framework of working. And I'll talk about, I'll maybe give some examples of how a clinical plan can be used by drawing references. So if someone is diagnosed with cancer and they go to maybe Sunnybrook, a physician might use what's called a biomedical assessment or biomedical planning to look for symptomologies as well as interventions to meet that presentation. If someone's presenting with a psychiatric presentation or a questioned psychosis, a psychiatrist might do a psychiatric assessment. Similarly, if an individual is presenting with behavioral concerns, a behavioral therapist can do a functional behavioral assessment, or a psychologist can do a capacity assessment. A social worker might be able to do a functional a family assessment or a psychodynamic assessment. And in the context of our work, we can work with a biopsychosocial assessment, which sort of speaks to the entire person. So I think in this most basic form, a clinical plan is a theoretically based explanation or a conceptualization of assessments. That's what it is in this basic form. So Dr. Yona says that a plan way is important to consider when working with, specifically when working with persons that may have complex presentation, as many of us work with persons that are dually diagnosed. So the purpose of a clinical plan or case formulation is to identify the best way forward and informing intervention. And there are some criteria that must be met if a clinical plan or a case formulation can be effectively done. And one criteria is it must be individualized to the point where it reflects and highlights the physical, mental, for some spiritual, social, and cultural elements that are important to that particular individual. The second is that it must be reviewed and updated to reflect the accurate presentation, the current issues at hand. And I think in my role as a clinical facilitator and working with many community case managers, I think this is probably the most difficult area in the planning stage, the point around the reviews and the updates. The third criteria is that it must be interprofessional or interdisciplinary. That the expertise of persons around the table may be very different and varied, but they're equally important in addressing complex situations. The fourth criteria is that as much as possible, including the client and or family in the planning, and I guess it speaks to the whole notion of being client-centered or family-centered, but more importantly, the point that families and clients are the experts in their own lived experience. And as much as we want to believe and go about and call ourselves expert, which we are, it is important, if you're working from an anti-oppressive perspective, to recognize the expertise of the family and of the client in that lived reality. And fourth, and I think most importantly, a clinical plan must be evidence-based. And the research suggests that if it is evidence-based, so that is moving away from, so I'll talk a bit about what evidence-based is, moving away from that reactive type of, I'm trying to find a more appropriate reference. But I think in the sector, people can be quite reactive when there's a situation and there's maybe a sort of historic way of doing things. And so an evidence-based approach is an approach that's tested, that is concrete, that is empirical. And I think there's a need for the sector in particular to move in that direction, especially around finances being tight. If we can get more buck or more bang for a dollar, it's important to do so rather than being reactive and responding in that type of historic type of manner. So if a plan is evidence-based, it will provide an overall picture or a map. So sort of think about a book, and at the very front there's a table of contents which highlights the chapters, the main chapters in the book. A clinical plan or a case formulation can be that content. So you have a very direct fact sheet that you can look at and that can point you to relevant and important information in a very concise manner. The second point around a plan being evidence-based is that it will highlight gaps in our service provision, as well as it can highlight gaps across sector. Gaps that might be evident in the developmental sector and as well as the mental health sector. So here's some more. The third is that if you do clinical planning or case formulation, you will have an opportunity to prioritize what is important. So, especially in complex cases, there may be multiple presenting issues that you have to sort of deal with. So you're putting out multiple fires, so to speak. A plan, though, developing collaboration with other professionals and family, you can use that to highlight what are most critical, what are the most current issues that need to be addressed. And fourth, you can sort of give you a framework to think about issues that might be troubling, that needs to be troubleshooted. The other purpose of clinical plan, based on the research, shows that if it is done well, you can achieve consistent approach with various interventions or tasks. That it can help service users and caregivers work together, which is difficult. We all come to the table with different opinions, and it's a human trait. We have different ideas about how things should be done, and it's extremely difficult to have people around the table working in a sort of coordinated fashion with those types of underpinnings. And it doesn't stick to any deficits within yourself. We're different, and when difference come together, there's bound to be conflict. A clinical plan, though, because it's very structured, it's very black and white, can sort of mitigate, maybe not eliminate all of those challenges, but maybe mitigate it a bit. It can be used to gather key information in one place, and when dealing with core issues, not just crisis management. And another important point is about it drawing on the expertise and values of all team members. And I want to make a point about this. Oftentimes you'll go to a meeting, and yes, there's a hierarchy in our health sector where physicians maybe the points are valued over everybody else's, as well as a social worker that may be credentialed might think her opinion supersedes that of a family member or someone that's not credentialed. And that is really unfortunate. I think we have to get to the point where and recognize that it doesn't really matter what's behind your name or what's not behind your name, that everybody's contribution is valid. And all of those pieces should be captured and reflected in our planning. Hopefully when all of this is done, so the plan being visualized, reviewed, and updated, collaborated with interprofessionals, including families. The idea is that we're working towards capacity building. And it's much more difficult than it appears. It is hard to, again, bring people around a table to do clinical planning. A clinical plan requires time, it requires commitment, and I think unless there is a recognition that it is important and valuable in our planning for our clients, then the shift towards accepting that that tool has been important is quite limited. So that's one challenge, and I think has been one that we've been faced at the CAIR program. I'm not sure how much value there is in understanding the importance of clinical planning. And that might be tied to a particular way of working. As human beings, we prefer working and doing things that we're familiar with. And so when a new idea is introduced, it sort of challenges what you know. It sort of pushes a type of paradigm shift. And I think because we might be so comfortable working in a particular way, because this is time consuming, and we know we're stretched for time with huge caseload and family visits, there is not a lot of time within people's calendars and agendas to do some of these work. But I think if we can step back and look at the evidence and look at research and really zero in on the benefit of clinical planning, then there'll be more sort of pedagogy, a type of shift towards that type of presentation. So this is an example of the plan that we use within CAIR, and it's framed within biopsychosocial. And then the idea, and I think it is in your handout, the idea of that is to highlight what is important for clinical planning. And it's to improve, in particular, consistency, not just with the teams that are working with the client, but across sectors. And in order for a clinical plan or a case formulation to be useful, there are some things that must be considered. And one is that it must identify presenting issues or needs. So that can be a client may need an assessment. So identifying that as a need. A family may need access to interpretation or an interpreter. There might be a particular cultural context where a client should not consume maybe pork. That should be considered and included in a clinical plan. So a clinical plan identifies needs as well as issues. The second point is it must highlight short and long-term objectives. So for example, if an individual is presenting with a question psychosis, what is our objective? Our objective might be to rule out whether there is a mental health concern or not. So being very clear about what our objectives are. And third will be the approaches and intervention. How are we going to go about addressing that need? How are we going to meet the need of a family that maybe are having issues with or a client that might have a mental health presentation? How are we going to get a physician involved, a community psychiatrist? Fourth is responsibility. Who's going to carry out those pieces? And more importantly, the piece around timeline. So for a clinical plan to be effective, again, it must identify needs, must have short-term objectives and long-term objectives. There must be very clear interventions or approaches. Responsibilities must be assigned, and this is particularly important in the context of CAIR, which is short-term. We're there for 6 months max. Who's responsible, who's going to carry this piece? And again, the plans developed in biopsychosocial, so the biological, we look at the medical pieces, psychological, we look at the psychological presentation, and I'm not going to go into details around this because there's a handout in your slide. And the social piece will take care of the social elements. All right, so just a reminder of the case we'll be looking at. Jimmy, 24 years old, his diagnosis are there. Severe physical aggression. He's ALC. His parents are deceased, and his brother is acting as his decision maker. There's instruction to sleep, eating routines. A medication review was done, and the BT is providing some consultation, and he was pulled for replacement. So if you're doing a clinical plan around the biological pieces, you might consider thinking about the medication review, questioning his psychological piece. Going back to what Dr. Yona talked about, ruling out any underlying medical conditions. So doing a full physical is important. You might consider referral to a sleep hygiene clinic and looking at his nutritional pieces as well. And it's important to do this in a very chronological manner, because the medical piece oftentimes can be, and especially for persons that are nonverbal, to sort of articulate, I'm in pain, it's difficult. So it's really important to rule out the biological pieces before moving into the other pieces. Under psychological, you might consider a behavioral assessment. You might consider safety planning, since there's some aggression. And staff training might be considered as well. And of course, a transitional plan, because he's moving out from the hospital. And around the social pieces, because this is, and again, it's important to look at the person fully. And the beauty about using a biopsychosocial framework is that it is so multidimensional. You're able to capture a full overview of the person. So you're not looking at a very siloed assessment. You're looking at a very holistic and comprehensive assessment. And I'm always very pleased when family and culture and all these things are considered in the planning, because you cannot understand someone's experience comprehensively or fully without understanding those underpinnings. His DSO profile update to ensure that his current needs are reflected. A PD, so I think that's the program, should be included in the plan, as well as a PDP, which I believe is a personal directed plan, and case management. All of those will be under the social elements. So, and I think in our program, what we, maybe a gap or a limitation from the hospital perspective, many of the social workers aren't very familiar with the developmental sector, and so many of the clients that may have a dual diagnosis are oftentimes not connected very well to a system. Their presentation aren't updated on the DSO profile, and that presents ongoing challenges. And I think I'm going to hand over to Olivia.
Okay, how are we feeling? Mid-morning, slouch in the chair a little bit. Okay, everyone sit up, stretch, touch your head, clap your hands, touch your nose. Say all right. No, it's all right. Okay, switching gears to the important theme of this series, right, is transition planning. So just with this show of hands, how many have been part of a transition of a client, of an individual, from hospital to home? Nice. There's some expertise in the room, I like it. To a day program. Cool. How many have led a transition? Awesome, okay. Good to get a sense. You're likely sitting at a table with somebody who knows something about transition planning, which is really cool. So make use of your colleagues, make use of the contacts you have made today and ongoingly throughout the series. Good, so it sounds like it's a relevant topic. Yes, no? Okay, why is this so important to the topic? It's another kind of clinical planning, okay, that requires equal amounts of time and effort, just like Leo went through. Again, the detail of it all, breaking it down into its component parts, just like a task analysis with my behavioral friends in the room. You're going to want to be really structured and explicit with the planning. Oftentimes, individuals are stuck in treatment settings, again, for many months, years, okay? And this again can result in a loss of skills, which can include life skills, social skills, lack of community access, disconnected from their social circles overall, their caregivers, their peers, and again, they become institutionalized, right? Even more so, more dependent on others overall. The cost of the systems. And I put it multiple systems because again, we do cross, into health, into the DS sector, into mental health. And again, just to give you a sense, the average cost of a hospital bed in Ontario is between $500 to $800 per day. At CAMH, it's estimated, now these numbers are a bit old, about $579 per day. And again, that can be dependent on whether the unit is secure or not. Right? Again, in addition to the cost of that hospital bed, the cost of holding, let's say, a bed in another sector for that individual to come back to, right, can be quite, so you're paying on both ends of the spectrum. So again, just be mindful of the costs. So again, that's why it's really important. And again, overall, having a dual diagnosis increases your likelihood of becoming ALC if you go to hospital. So those who stay 90 days or more or over 6 months have very complex conditions and needs. And I think we know this and we experience this. They're more likely to have schizophrenia, psychotic spectrum illnesses, dual diagnosis, and co-occurring physical illnesses, which again we've heard from previous speakers. Many exhibit problematic behaviors and or have legal involvement as well. Okay? So a really good resource was Butterall et al. 2009. So if you want to learn more about some of the numbers within Ontario, which is cool to have a local context for all this stuff, check that out. What are some barriers to discharge? Have we experienced barriers to discharge? Maybe just with a show of hands again. Head nods. Yeah, okay. Right? This is why they're ALC. So again, we need to really think differently to accommodate these individuals. And some of those common barriers, I think, can be really addressed and have a solution towards it. One of them, again, this sort of is echoed and repetitious to what Leo had stated, but it's good to repeat these common themes because I think it's hopefully that can stick then. Clients are often left out of the discharge process, okay? And with this, there becomes just less understanding overall of what this means to them. They may become less cooperative, and again, they're not able to share what they want or what their needs are for this new setting. And again, they could pick parts of a transition and parts of a meeting to take part in to get a sense of what they would like and need. And so again, when the individual voice cannot be heard or communicated, we need to look to the family as the experts, as Leo had echoed as well. They are our best historians, so we need to embrace them and pull them into that process. And again, oftentimes the family's not considered, not at the table, which again can also minimize and limit the extent to which they support that transition and are on the same page as everyone else. Okay. Not involving both parties early on in the planning process, and again, so both parties, I mean that discharging location to the receiving location. Okay? And all parties not having a good understanding of the other service or capacity. And again, I put hospital versus community. I shouldn't put versus because it should be an and together, right? It's not a his problem, her problem, it's our problem, our united problem. And again, to really emphasize that time is needed to get everyone on that same page about the transition. And this will help all parties understand what their expertise are and identify any misconceptions right from the get-go of the other's capacity. Oftentimes the hospital is not aware of what that community is even capable of, right? And what, even what a group home looks like. So we need to be mindful of that and take it on ourselves to educate around that. Again, some hospitals don't even know the ratios or how it's set up, how they're connected to day programs and all those other services and supports that wrap around. And again, hospitals we need to recognize can be quite conservative in their risk assessments of individuals. They often don't have an opportunity to trial out some of those assumptions of they need one-to-one. Well, how do we know that, right? This is in a limited context. How can we work together to figure out and trial whether they actually do need a one-to-one support? So again, working together to be creative and test those assumptions would be very helpful in this time of transition. And both need to really understand, the emphasis needs to be around that discharge does not happen in a day. And really like keep that forefronted, because that needs to be the messaging for everyone at the table. Okay, so we also know a lack of high support housing options and flexibility within the system. It's quite limited. We don't have much to work with, right? So again, we lack that full continuum of housing alternatives, which then restricts the flow and movement of clients into appropriately matched placements, right, and appropriate level of need. Long wait lists, resource shortages can greatly contribute to this and can result in clients being placed in housing that really understands them and is a real disservice to them. Again, if we can have flexibility with funding and the ability to move, let's say, money a little bit more fluidly through the system to different parts of a transition, then hopefully we can better support the individual and maybe even build the supports around the individual. And again, you know, there is still a lack of capacity within the community to be able to really support and deal with complex mental health needs. Again, there's overall shortages of personal care workers within housing, which again becomes problematic as well. If an individual really needs high support for their ADLs and are aging, let's say, and becoming more complex. Teams require requisite expertise, knowledge, skills, and attitudes to work with these individuals, including really skilled and training around prevention and management of aggression, crisis intervention, and doing some sort of risk assessments in the community. And without this kind of training, this can, you know, add to overall stress in the group home, in the team, and then result in, you know, staff turnover, burnout. You can see where this is going, right? And again, that stress can then transfer to the client, which that's the last thing we want to happen, right? They want to feel welcomed and supported in their new home. So, who's experienced these transitions? Nobody. That's great. Okay, let's flip the coin now and let's talk about what is a good transition. What are the elements of a good transition? Let's keep it solution focused if we can. Okay, so opposite to the last slide, tailored to the individual needs. Some of these are going to sound pretty obvious, but how do we do that, right? It should be viewed as active participants because they're able to tell us whether something is wanted, needed, if they like it. And again, we can look at their ability to communicate to us effectively and can also look at elements of assent. So what is their presentation, their body language telling us about a certain element of a transition? Service providers need to be, again, flexible with information and of the client's preferences and be creative in how to incorporate that into the planning process. Again, messaging needs to be clear to clients as well that hospitals are not for life. And that should be repeatedly messaged from the start, right? As soon as they get ALC designation within the hospital or even before that, it needs to be, we're trying to find a better spot for you to feel more supported and a better fit for you. Carefully planned. Can't emphasize this enough, and again, this goes back to hit it with appropriately timed. And again, that clinical plan can be really relevant in this point. And this includes not only gathering all the relevant players to the table and making that really strong clinical plan, but also that transfer of knowledge. Again, building that binder that Yona was talking about and having that be part and relevant and present in those meetings. And allow time for training and overlap between that discharging location and the receiving location. Request it. Sometimes if you don't ask, it's not going to be given, it's not going to be offered. And maybe we just have to be flexible as to where the clinician from the hospital is willing to meet you, let's say in the community. Maybe you could build some negotiation around that. And again, could the hospital team come out to the setting that you're thinking of? Could the family, could the client come out to that new space to see if it's a good fit for them? And again, the idea of trial placements I think is a good idea. Not a full commitment to the space, but a short, maybe a month or so into the new space to see if it's a good fit. Again, I'm just mindful of time. So I'm going to move a little bit more quickly because it is repetitive, but I think it's good repetition. So again, families, they're our best historians, so we need to remember that and really include them and be transparent from the start as to what this transition process should look like, and what are the considerations and timelines for it. I think if one family hears that a slot is full, they get really excited and really try to move really fast, but at certain times we need to know when to slow down a little bit. It needs to be appropriately timed, so again, we need to build that checklist, that clinical plan. A concrete transition tool can be used, which you guys have a copy in your packages about. And again, that's going through that to-do list to make sure we can satisfy all those checkpoints. And consider the timing of transitions, not over long weekends, not over holidays, not over Ontario Review Board hearings, maybe afterwards, so that there's a little less stress in that whole transition. And again, the last one, which CAIR harps on often, which I think is a good harp, collaboration and shared accountability, moving away from working in silos and the idea that this is your problem now. No, let's work together to make this a solution together. An example from yesterday's forum was that hospitals are willing to do take-back letters. Just an idea to help percolate and keep that always in the front of mind. Again, if you don't ask, you won't get it. So, okay. So ALC trip, you should have it in your packages. Transition and resource implementation
for a little bit.
Who was previously in this role. And it really what it does is have a slot for you to fill in each of the key characteristics of a good transition. So it helps to highlight the full process, breaks it down into its component parts, and really helps everybody think of all the different elements. So we will get that to you after today, but in the meantime, we're going to review Jimmy and how we can support Jimmy within this transition tool and transition planning in general. So everybody has that case of Jimmy, and I'm going to put up some questions for you guys to consider, and then we'll within at each table have those discussions. Somebody takes some keynotes, and then we'll open it up to get some feedback from you guys, okay? So I'm not going to review Jimmy again. Okay, so at your table, we're going to do about 15 minutes. 10 minutes maybe, actually. 10 minutes. So start talking on these points. So who's going to take part in the transition team? What key information should be transferred over? And again, you're going to have to infer a little bit here. I don't think the case study's too beefy, so just put yourself in a case that you've been in similar to Jimmy's, and think of just be creative about what kind of information and try to infer a little bit more onto the case. Are there going to be transition visits? And again, think of both ways, people coming to the hospital or people going out of the hospital into the new location. What services and funding are available in the community setting? And what services and funding are missing? Okay? Good? Go for it. Okay, let's talk about Jimmy. We should have a mic.
I know, sorry, I got off with the
Okay, so we'll just keep this free flowing. Hopefully people are willing to share. And
Sorry, that was
okay, some considerations for Jimmy and transition planning. So who do you think is going to be part of the transition planning? Who are those key players? I heard somebody say Jimmy. Yay! Let's pull him in. Let's see, right? Why not? Maybe we can have a smaller meeting and talk to him about some of his thoughts and needs, and then have that voice leader and his brother can share that with the larger team when it's a more formal meeting. Who else? We could do this two ways. We could do, I guess we do have to go through the mic, don't we? Yeah. It's really hard to hear each other. Yeah.
Jimmy's brother.
Absolutely. We know Jimmy's brother has taken over CAIR, right? And so he's going to be a key player. He needs to feel probably really supported in this process because this is a huge transition for him and his brother, right? Both of them, the family. Yeah.
Staff at the home that he may be moving to?
Yeah, pull him in early, right? We talked about this. again, and try to bring people who have the power to be creative. I think we heard that yesterday. So people who can make some decisions, right? They don't have to necessarily go back to check on whether something is possible, but they can make that decision there and then. So again, maybe supervisors, managers, maybe a primary worker if they've been identified, right? So again, that person can be a point person, can start that rapport building with Jimmy right away. What about from the hospital?
Current staff that are working with him? Sorry, we can't hear you, sir.
Well, or if you want to repeat what they say,
Yeah.
that's okay too,
Okay.
but for short stuff, yeah, go ahead.
We said over here, the current staff working with him, so on that unit, right? Is there a recreational therapist? Get that BT at the table, right? See if we can get time from the psychiatrist as well. Usually there's a primary nurse assigned to people, so let's see if we can get that full medical history, at least all the tests that have been done while he's been in the hospital, to come to that meeting, so we can figure out what are the pressing needs. Yeah, because we do know he has diabetes or pre-diabetes, so what kinds of things are we going to have to be thinking about when he moves into the community, when nursing is not going to be able to support him to do that kind of testing. Okay. What about the key information? What kinds of reports are we going to be asking about? Behavioral report, yeah. Psychological, so we know it's still pending, it hasn't been done. If there's an old school one, so how can we get a hold of that? And we gotta think and get on that quickly because those things take time. But maybe thinking later on about psychological assessments. Do we want anything from the hospital?
Med review?
Med review. What current meds is he on? What are some current side effects maybe? Is there any blood work that needs to happen regularly? And again, those conversations can be started really early so that can be planned for once they're in the community. Does the nurse come to them? Did they go back to the hospital? All those kinds of things. Any other key information that would make you guys as community members comfortable?
Yeah, behavioral summaries of his time in the hospital, he's been there for a number of months.
Definitely.
So I want to
Behavioral
know,
summaries.
I want to know what possible triggers there are for him. I know hospitals are artificial settings, residential settings, but it may have some useful information.
Sure. What are those antecedents? What are those triggers? Again, can we plan for and prevent some of those from occurring in the new setting? What's the presentation? What's the frequency, intensity of the behavior? What's currently occurring on maybe some really current numbers to get a sense? So then we can see, is anything changing once he enters this new space, right? A transition alone is quite stressful, right? So we're likely to probably see some kind of escalation or increase in presentation. And then how are we dealing with it? Can we deal with it the same way that the hospital deals with it? These are all the good questions. Is there a PRN that needs to be considered in this? That then you guys need to rally the doctor signing off on all those plans, right? So then you can administer in the community.
Just saying that with the diabetes, looking how that will affect the glucose and the training that might be necessary in glucometer and so forth training for staff.
Definitely.
But also,
Diabetes training.
if the individual Jimmy has diabetes and the hospital is the one, or pre-diabetes, has identified it, have they identified a nutrition plan? Have they identified a community practitioner that can then be either the diabetic nurse or the diabetic contact in the community? Sometimes like the local health network, or the local community. I'm thinking the Albany Clinic. I don't know what those are called, like that.
Yeah, where can you get that expertise in the community? And start thinking about it now because you might have to make referrals and all that stuff surrounding diabetes. Maybe there needs to be staff training on how to support Jimmy in doing his blood testing. So again, understanding what is a high blood sugar level, low, all that education piece to keep him healthy. What kinds of diet considerations should be considered? Definitely. Okay, I think that's a good summary of that. And again, that links into what services might be present or missing. Yeah. Okay, do you think we should have transition visits for Jimmy? Yes. Yeah, and we have to be really creative about what these look like. Can the primary support worker come to the hospital? Yeah, start building that rapport. Start to get to know what his routines are. We know he's struggling with his routines right now, but what is his baseline in that? How does he shower? How does he do all his ADLs? All his daily routines and hygiene things. So we can try to transfer that over really similarly to that new group home. Keep it as consistent as possible for him. Does he use visuals? Again, try to bring that over as much as we can. What about the other way? Should the hospital go to the group home? Yeah. Why not, right? And again, you have to sort of ask the questions. You have to sort of push and be like, hey, could the social worker and the BT come out and do a staff training for us? And that way you can then see the space, you can see where Jimmy's room will be, and what kinds of supports, and help us brainstorm how we can replicate or not, right? So things.
And not to forget the environment, right? Like he's going into a brand new community. If he's going into a brand new community, also consider the community as part of his transition, however that may look like. Because instead of going from a potentially isolated institutional setting to community, you don't know where you are, you don't know where the local anything is. So having that as part of an overall transition plan, whether it's after he moves in or beforehand, you would do that if you bought a house.
Definitely. And let's include brother in this as well. Like, let's get him over to the house, so he's very comfortable and it's very transparent as to what they're saying yes to. Definitely. And again, that primary support worker, if they visit at the hospital, and, a couple of weeks ahead or a month ahead, then they can also come to those visits at the home and be that bridge, that familiar face. Okay, and I think we have a bit of an understanding. So what are some of those key things that we're gonna want to see if we can source within the community for Jimmy?
Well,
It's identified that he hasn't accessed or attended a day program, so he needs to find something meaningful for him to do during the day. And as a precursor to that, I would suggest a person-centered plan for him to find out what he likes and what he would like to do, because he's only 24, he's a very young individual, so he probably has lots of energy and would like to, have some fun, maybe with his other 3 roommates that he's going to be living with. They might find something that they all have to share in common, and might be sort of like a little icebreaker before he actually moves in with his friends, so that he's already got an idea of who his friends and something to look forward to during his day.
Definitely, and maybe that day program, so you'd have as a team decide whether that day program planning should happen before the move or after the move, and get him settled in first, then he transitions to the day program, or have it already in place and him already transitioning from the hospital to the day program prior to the actual residential move. So again, it would all be very individualized to Jimmy, the brother, and what kinds of clinical opinion around that would be. Yeah, and again, you can see how the clinical plan that hopefully is done prior to this kind of transition planning would highlight that PDP need and that idea of the person-centered plan to get a better sense of his preferences and goals for life. Absolutely.
So I'm going to suggest we got a few more minutes for the next presentation, so maybe it's a good chance to finish up with Jimmy for some questions. So I want to make sure people have the chance. And I just realized too, we should definitely pause to get the mic, partly also to support our interpreters so that they can hear clearly. So I do ask you to put your hand up and we will bring you the mic. It just makes it a bit easier. I know I'm really loud and I know I can fill the room, but we'll do that process and it helps make things go more smoothly. So.
Yeah, let's open it up to questions. I think Jimmy's in good hands, especially with the expertise in this room and the kinds of learning you guys had today. Just bring those to the table, bring those themes to the table, and try to advocate as best you can for Jimmy and others. Thanks, guys. Question?
No, I think you guys, unfortunately, aren't going to be able to stick around, or are you sticking around for lunch?
So Leo and I can stick around for a little bit. I know Cynthia has to jet off.
Yeah. Oh, there's a question. Here we go.
Slightly off topic, but while you're here, has this been tried from shelter system to a home environment? And in addition to that, we work at a Seton House homeless shelter in Toronto, and coupled to VD, there's homelessness, and also really significant addiction issues. So has a harm reduction approach been trialed with this? And any comments on that?
So I can probably respond to part of your question. In regards to a shelter system, so a program is currently supporting an individual in that setting with other professionals as well.
Are you referring to the Bridges to Housing?
No.
Oh, okay.
An entirely separate shelter. I think once there is someone that can operate or hold a clinical plan with myself, we're able, and the person is eligible through the DSTO, we're able to be involved to develop a clinical plan as well as to help with the transitional support. I'm not sure if that answers your question entirely, but we are able to support persons within the shelter system.
And again, it could be the interim solution until a better placement comes up, right? That maybe is a better fit for the individual. So we have done that sort of step down or step to the side kind of idea, and then come back to what is the ideal for this individual.
Any other questions?
Yeah, just briefly, when someone's in the hospital and they're going to be discharged, does the hospital have a legal responsibility to make sure their discharge is as safe as possible for them?
That's a very good question. I can't speak to legally what the hospital is responsible for, but as a community member and people who are trying to advocate for their services, we can always highlight what their needs are and try to advocate on their behalf. What they're responsible, I can't speak to. I know what we can talk to in terms of what are the best practices and share that knowledge. I think fundamentally our experience has been when hospitals have the pressure to discharge, they respond very positively when we present them with these clinical plans. So it kind of allows us some time if we come to the table with a plan in place. And usually when we present them with a clinical plan that the community has informed, they're more willing to provide us that room to do that work that we need to help with the safe transfer out of hospital into the community setting. We have had that experience. Of course, they have their own pressure, so we have to be mindful of that, and that's why we want to hold each other accountable. But our experience has been when the pressure is to immediately discharge to whichever location that the bed is needed, and it's, we've had different discharge locations that we wouldn't think is appropriate, but it's what happens. We found that when we come to the table with a full plan in place, that they're more likely to allow us some of that room to do the work that makes it happen from a community receiving perspective.
And I think just a quick another note, that with the idea of trial placements, say for a month we're going to try this out, but is there an opportunity to take back the individual who's really going to break down?
Sure.
So.
You grab one of the mics. Yeah, bring it up. Where?
In light of that question, I found sometimes supporting the family or system to involve an ethicist. That's a great avenue to kind of gently begin the process of pushing back.
So thank you very much. Can we get a round of applause?